All right, then we're off. So first of all, welcome everyone, and many thanks. Also, special thanks to Terry and to Alvin, who've made this possible. So I very much appreciate it to be invited here to present on this forum. And I'm keen to to engage with you following this presentation. So perhaps a bit of background then. S23M, as Char mentioned, we've been around since 2002. And over the last year or so, we've invested heavily in the development of what we call the S23M CAD Platform, which is the foundation of 5 product lines that we offer to the healthcare sector, software product lines. So those are new product lines. We are still in the process of engaging with prospects, so we can't yet show you a live customer that runs on the CAD platform, but well, decades of domain expertise have flown into the design, and we're having very interesting conversations. So we're a small company. We are developing and offering enterprise software and consulting services with best-of-breed solutions that are based on our unique insights into human factors. So we operate out of New Zealand and Australia, and we have a dedicated product development, operations, and support team in the Philippines. We have international sales partners in Germany and Spain. So basically here in New Zealand and Australia, we have around about 15 consultants, and then the technology team in the Philippines, that's another 50, 60 dedicated people. So that gives you a rough idea of our size. Beyond software, as Char mentioned in the introduction, we also offer community-oriented co-design services to the healthcare sector. So this is something that we initiated also last year here in New Zealand, based on the needs of, well, underserved communities and the challenges we have here in New Zealand is the population is very, it's highly distributed. We've got very low population densities in certain quarters, and getting services to the right people can at times be challenging. We have deep expertise around clinical data governance, and one of my colleagues is an expert in cybersecurity. So that's another core area of specialization that we have. Then, we have software services. So those are all web-based product lines. So everything that you need to run these things are a web browser and an internet connection. And of course, we also offer system integration services and based on open interoperability standards, which is a topic that my colleague Keith Duddy will talk about in, I think, the next meeting. And here in this corner of the world, not exactly Asia, but Trans-Tasman, we've been facilitating a Trans-Tasman knowledge exchange in relation to the dynamics of the pandemic. So we did that last September. That was very interesting and successful. Served first a lot of interesting insights, which are openly published on our website. And we are actually now in the process of continuing this on a bi-monthly basis, so all the results will be available in public. So our 5, or rather now, I think 6 product lines for software product lines for the healthcare sector. I think For this audience, the most interesting ones are going to be the first two ones. So there's the patient journey management product line that we offer to hospitals that tend to coordinate healthcare delivery across regions in New Zealand. We are now in the process of integrating with the OpenMRS, open source electronic medical records software. So that's obviously also for hospitals. So this is the core of what we do in the hospital space. But then the interesting thing about our software is that there's this underlying CAD platform. So those are shared data structures and also reusable data assets that allow us to provide seamless connectivity and functionality and support to all those who work in for allied health service providers, operators of retirement villages and the like. And then we also support community networks of care. So those are healthcare professionals. Those are local communities, patients that may want to take custodianship of their health data. And then we have tools for professional networks of healthcare professionals, like, for example, nurses. So to give you an idea of the functionality, I'll keep this fairly brief because this presentation is intended to be about the architecture and interesting aspects of the architecture rather than the functionality. I think so. If you look at this overview of functionality, you'll probably find many things that you are familiar with. So it's managing services, managing clinics and associated resources, supplies, managing healthcare service providers, managing facilities and equipment, integrating with other systems, in particular clinical systems, and then having portals for patients and non-healthcare professionals to interact with the ecosystem, and then lastly, support for invoicing and billing. This year, when we talk to our clients, I think the agenda is dominated by COVID-19 and in particular immunization programs. So in this context, we are working on software to support this in a way that actually works and is adapted to the local context, for example, here in New Zealand or Australia. And what we find is that there's demand for additional consulting services around the software, because obviously software is never used in a vacuum. It's used by people, and these people need to collaborate and need to be supported in the ways that they need to collaborate. So let's perhaps cut over here to our methodology as the intro to the architecture. So we talk about so-called model-oriented domain analysis and engineering. And this is a systematic approach for analyzing commonalities and variabilities across the needs of all customers and potential prospects in a particular geographic region or jurisdiction, or even across jurisdiction, and then to source and surface the domain knowledge needed to hide all the implementation details from users of configuration tools, so that configuration of our product lines can largely be done by customers and the domain experts on the ground. So this is an approach that is very systematic. It's used by some software product companies. I would say maybe around 5% of software vendors have managed these types of techniques, and those tend to be the vendors that are the most responsive. They're not necessarily the biggest vendors, because the larger the software organization is, the less agile it typically becomes. And the more they become, professional service companies rather than software companies. So here in this diagram, you sort of see what we're talking about here. So there are three things that matter here. The mindset when developing a solution, the design focus, and then the management focus. So if you're a healthcare delivery organization, then you're not a software vendor. So you're not really thinking in terms of products, you're thinking in terms of solutions, and you run projects to deliver these solutions. And to do so, you may look for the assistance of by off-the-shelf tools, say for some vendors, and then you try to integrate them into your particular landscape. Your management focus then is on solution delivery, and you need to manage the project. If you operate in that sphere, you don't necessarily have the broad overview as to what may be relevant in other geographies and other jurisdictions, and you don't have any good feeling for how common certain things are that you're doing, whether there are perhaps even better ways of doing things. And so even software companies, when they're operating as a professional service provider, I would say that they need at least 3 customers until they're able to go beyond projects and to start thinking about products. So what happens then is when you start productizing your knowledge and expertise and functionality, what you're effectively doing is you're acting from a motivation of opportunistic reuse. And what you're doing is you've got fewer unknowns and you're exploiting that. Now, once you then reach 100 customers and more, then you're in a different terrain. And unless you want to scale up people into the hundreds and the thousands, you simply can't do that by operating in a product mindset. So the product line mindset is quite different. So there, what you're looking for is what you want to tap into all the available domain expertise that you have from all your customers and all your prospects. And you may have hired people who've been active in a particular domain for decades, and you want to really put their knowledge to good use. And then what you focus on is cost and time bottlenecks, and you want to develop advanced power tools to support strategic reuse. So reuse not only of software components, but also reuse of data assets, methodological building blocks, and so forth. And then also the focus shifts from supporting products to product line operations and managing an entire family of software products. So this approach is not new. It's been around for, well, around about, I would say, 3 decades. But as I was saying, it's a minority approach. It tends to be used by mid-size and smaller vendors who have deep expertise and who offer best-of-breed solutions, rather than big vendors who try to offer generic tools and then sell them to everyone under the sun. So what you need here is the 3 key ingredients are architecture, because that gives you, if you do that right, you get a core set of reusable assets. Then you have a methodology that gives you a clear production plan for not only one product, but an entire product family or multiple product families. So this is more complex than your typical project plan or product roadmap. And you need to look also at the business case. You need to understand exactly where the value proposition is, so that you offer exactly what meets the needs in the different segments of your market. So the work streams that are involved in developing and maintaining and operating a product line are the following. And so this is perhaps where you see that this is a bit more involved than what you would get by, say, adopting simply an agile approach to developing a solution. So here you see very clear distinctions. You've got the customers who operate the product line. So they do their daily business, which is very fast, many transactions, and the focus, there you want to monitor that this is working at the right performance level. You want to manage incidents, have that capability. The actual product development itself, what we call product engineering, this is, in a product line engineering context, this is highly automated. It's highly, it's more a matter of configuration than actually coding. So there's, in our case, there's no coding involved in product engineering. And then, of course, you want to test it with end users. So when you take a product line approach, product engineering really feels like working with Lego blocks. So the really interesting things go on in this work stream that we call platform engineering, where you're thinking about, well, what are the Lego blocks that you actually need? And in order to do this, you need to have this very clear view of what are the dimensions of variability across your entire target market. And then you need to build these Lego blocks. And on top of having the Lego blocks, in order to automate and simplify the product engineering, you even want to create tools that partially automate the construction of solutions from these blocks, because in a non-trivial product line, well, you'll have hundreds of blocks, and you want to make it easy. You don't want to need technical experts to plug together a solution. So this is an important aspect here, making that easy for end users and domain experts. And of course, the technological landscape is changing all the time. So the infrastructure, and this is why beyond platform engineering, you need the ability to experiment. And this is best done in a separate work stream so that you don't pollute your clear thinking about the problem domain with thinking about new technologies that appear on the horizon where you don't yet understand them in detail. So you want to run some experiments, possibly multiple experiments in parallel, to then, in a very informed way, to introduce some of those new validated technologies into your product line architecture. And of course, you've got feedback loops here between these streams. So, and if you think a bit about this, what you discover is that this entire approach that I've been describing here actually is based on evolutionary principles. It's based on evolutionary theory. So you've got these elements here of variation, selection, and replication, right? And the product line engineering at the core is a selection process. And the experimentation that you do, that's where you consciously create variance and see what works, what doesn't. And then when you expose these things to customer, you want that to be an easy process. So that's the replication process. And then customers, well, they want to be able to sustain their daily operations. So the color coding here is not random, in case you may wonder why I'm using these colorful slides. So the color coding is designed to highlight rates of change. So the design principles, they are very stable. They don't really change. So we've got a very good handle on the design principles that we need for creating product lines in the healthcare sector. I mean, this is why we've been able to create this CAD platform within less than a year. The rate of change of the core assets that you have, so that's what we do in platform engineering, that's also quite slow. You want that to be stable. So those are like the dimensions of variability. It's not the actual values of your variables, but it's the variables themselves, the set of variables. That's stable if you've done your domain analysis adequately with the right kind of domain experts. The configuration that customers do, the product engineering, well, that's, yeah, you want that to be really fast. So there you've got a much more sort of rapid rate of change, and things get even more rapid and even hectic in product line operations. So this is where the customers are actually doing their daily operations. So here to map this to the concrete user interface that we have, you see it here in this diagram to make it perhaps more concrete. So the design principles, this at the top, well, they are the backbone of the whole thing. So that's like the invisible thing that you don't see. The user interface, we've organized the menu in such a way that towards the top here, the largest part relates to your daily operations as a healthcare service provider. So you see there patients, appointments, referrals, equipment management, and so forth. And configuration is the second to last item here on the list. This is only certain people get to do this. And in our case, we want to empower, however, the power users of our customers to do this. And what we provide out of the box are global, national, and regional standards and data sets. That's what we call the CAD platform. So this is something where our customers don't have to do anything. This comes reusable out of the box. And then behind the scenes, we conduct our experiments. So there you see the practical example. I won't dwell on this slide here. This is just an overview as to what we mean by assets, reusable assets. So everyone assumes, I guess, that there will be software assets, but there are all these other things like domain models, architectural patterns, related documentations, test plans, user guides, and so forth. So our CAD platform, that is a collection of reusable data assets and functionality. And so for hospitals, we talk about patient journey management because we are able to weave together all these different concerns. So everything from, the clinical side, which can be covered by OpenMRS or other clinical electronic health record systems, then accounting systems like Xero, functionality from companies like Google or Dropbox. All these things are integrated out of the box. So here you see examples of concrete assets that are part of our CAD platform. The colored entries here are those that are visible to our customers. So things like user guides, tutorials, demo data, example instances, example data, product line roadmap, then our whole sort of QA process, release process, and of course, the functionality itself. So there's a lot of things here. We can visualize this. I will, in the interest of time, I won't lose much time here. So this just shows we're able to create several product families on top of the CAD platform. So serving a whole range of different types of organizations involved in healthcare delivery. This ties back to what the Software Engineering Institute likes to refer to as these three important ingredients. So one is the core asset development, then the actual product development for specific customers, and then the management and coordination of both sides. So on the left here, you see our product lines. On the right-hand side, you see example prospects where we're having discussions. So this whole product line approach, even though it's only used by a few vendors, it's well documented. There are a whole number of books on this topic that explains how this works. And now to get, to move away from the technology, in our world, in order to create best of breed product lines that are fit for purpose and that meet the needs of real organizations, for us, there are three important use cases, and each one is they're all equally important. If one of these 3 use cases is not adequately attended to, the whole solution or product development effort can fail. So there is the actual functionality. So that's what, in terms of design, that's user experience design. But then all that must support the actual collaboration between people and their needs. So that's language design and cultural evolution, because if you provide new tools, well, the way things work will likely change, and hopefully it will reduce the cognitive load of the people involved. And then, of course, in today's world, most systems are not disconnected. I mean, we live in a network world, so these systems also need to talk to each other. So interoperability and standards design is a really important topic here. So we've just seen aspects of the architecture and the principles that we use in the CAD platform. And now we'll look into how we engage with communities and with end users and people. So in this domain, 2 things are really important. The first one is mutual trust. And there's a number of principles and techniques that we tap into there. So to maximize psychological safety, there's also the design justice network principles that support psychological safety and also adequate representation of minority interests. Then there's a number of pro-social principles that we actually also use within our organization, and we assist customers to adopt this. And we make heavy use of open space workshops. And then we have some tools to surface collective intelligence for tackling wicked problems. So this is where we ensure, that all the right people are in the room by giving a voice to minorities. We have a backbone of 26 critical thinking tools, and we use a technique called multi-solving. So communal decision-making and ownership of decisions is really important. So here's just a slide that shows that this was one of the important insights that was reiterated, I think, several times as part of this Trans-Tasman knowledge exchange on the pandemic that we conducted last September. If you recall, when I talked about our methodology, I mentioned the term model-oriented. Here you see what I mean. We make use of the resources, events, and agents paradigm, which is a very simple technique to record the most salient aspects and to surface the dimensions of variability in a particular domain. And we embed this in the SIKI, the socialization, externalization, combination, and internalization knowledge creation spiral. So we are very aware that not all the knowledge can be made explicit. The tacit knowledge that the people have and always will have, that is as important. So how do you apply this? This looks abstract. So in concrete terms, we can describe patient journeys and patient support in terms of resources, events, and agents, and underlying motivations. So obviously the patient is the primary agent. Then we've got events. So that's how we describe patient journeys, as a series of salient events. And throughout this journey, the patient interacts with other human agents and with various technology agents. And each agent has motivations, and we record those so that we understand the context. And well, patient needs are met by coordinating the availability of resources. So here you see some example agents, both external and internal within an organization. So there you see the visual modeling notation that we use. In terms of everything around collaboration that we do, I've just written a book on this topic that is currently being peer-reviewed, will be published in the next few months. So because I thought, yeah, beyond the technology, it's important to give people some guidance on how to surface this tacit knowledge and to put it to good use. So to summarize, we offer best of breed functionality. That's our aim, and we don't reinvent the wheel. That's why we integrate with OpenMRS and other excellent tools that are out there on the market. We operate very closely in close collaboration with standards authorities and with the local ministries of health, both here in New Zealand and Australia. And we're open to, well, venturing beyond this sphere here. So we've done significant work overseas in the past. And I've also actually done some work in the Philippines many years ago. So we're open to collaboration. Here we see some sample screenshots showing how we pre-configure the system with various things for a local context. So here in New Zealand, yeah, we've got all the regions, and regions can be nested, and standards can then be attached to either regions or to the whole country or to even at a smaller. So we are very flexible in terms of the scale. Everything is multilingual. We can plug in different technical terminologies, formal terminologies that are standardized in healthcare. So the architecture is ready to go, and well, it can be deployed anywhere. As you would expect, workflows can be configured without deep technical expertise. Yeah, coming back to this topic of trust, I think this is the critical ingredient in our experience. So the technology these days is no longer the bottleneck. The bottleneck is having trusted relationships with everyone who is involved, and that includes all the healthcare professionals, and even more importantly, includes local communities and the people who live in these communities and who have specific needs. And unless you enjoy the trust of those people, you'll never even know about all their needs. So from a data governance perspective, we realize that in different jurisdictions, well, jurisdictions can be different, and data governance regimes can be different. So this is also configurable in our CAD platform. So here we see examples, New Zealand and Belgium. There are significant differences there. So in New Zealand, the district health boards collect a lot of information and in many ways are the main data custodians at the moment. In Belgium, the GPs are the main custodians, and hospitals are only allowed to keep health record information for limited periods of time when they're dealing with particular patients. So there the picture in many ways is reversed. And what we see in a number of jurisdictions, or what we see down the pipeline, increasingly based on changes in legislation around privacy, that increasingly I think patients want to be empowered and are expected to be empowered to take custodianship of their health data if they wish to do so. And if they don't wish to do so, then probably they'll appoint a trusted party to do that on their behalf. So we don't want to recode anything. So we've made this absolutely configurable, empowering patients. And so that means health information, we conceptually store this in personal data stores as needed. This type of information can be encrypted and secured so that the authors, clinicians can be sure that the information is not tampered with, but patients, if they want, can take ownership of the privileges, the access rights to this information. So this is, I think, quite unique about our architecture, which effectively allows distributed data governance and is ready for And I think that concludes this quick overview. I'd like to close here with just a one-page showing how we work. So we engage with healthcare organizations typically by sitting down with them to confirm the scope as to what they need. And even in parallel, here in New Zealand, certainly, we not only talk to healthcare organizations, but we directly engage with local communities so that we already understand the local context before we even talk to the hospitals, for example. This then allows us to proceed down a path of domain analysis, where we bring together the clinicians with local communities and people from outside the organization to really get all the tacit knowledge around the table that is needed to configure a solution. And well, as I outlined, I think in our approach to the CAD platform, configuring the solution is not the bottleneck. That's easy. What can be more involved is the solution design, getting access to all the right people, and then the system integration, where, of course, many organizations have legacy systems and they expect the solution to be integrated with these systems. And this is something where we have deep expertise, and my colleague Keith will talk about that in the next meeting to give you an idea as to what our capabilities are and what our experiences are, both in New Zealand and in Australia in that domain. Yeah, then performing the actual system integration. So there we've got capacity on the ground, both here in Australia, New Zealand, and in the Philippines. And we, of course, support our customers with things like data migration, quality assurance, training, and then ongoing 24/7 support. And I think this concludes my presentation. And I'm keen to hear from you whether this is of interest or whether you've got questions. Let's have a discussion.
Thank you, Sir Jorn. We're now open for questions. If you don't have your microphone, you can type them in the chat box, or if you have something to share. And we also enabled the microphones and webcams of participants. So if you have questions, please raise your hand. Our first question is from Sir Terry. Sir Terry, would you like to use your microphone?
Yeah, Jorn, hi. Good, nice presentation. Tell me, at what stage do you engage the end users? At the start?
The earlier, the better.
Right, right.
Because we don't like to speculate. We don't pretend to know what is in the end user's head.
Right, fantastic. And I was just about to type one more question, if you don't mind. You talked about the transitory storage of the data in the hospital. What happens, do you perceive as happening to that data, which of course should not be lost, but where does it sit into the functionality of the patient flow?
Well, if you're referring to the comment that I made about the data governance regime in Belgium, I mean, this is very country specific. So what I was really trying to point out simply is that different countries may have very different laws around data governance. And even to the point where, you know, there's strict regulation as to which organizations are able to keep permanent records of specific types of information. And I thought Belgium is an interesting example. It's quite unusual that the GPs are the permanent custodians of patient records. And the reason there is very interesting. It's got to do with, well, with data security, because an individual GP only maintains, you know, a limited number of patients, whereas hospitals serve, well, hundreds or thousands. You know, it's much many more patients and many more health records. So from a security risk perspective, hospitals are much more exposed if you make them the permanent or the primary custodians. Now, from our perspective, we don't really care which organization so physically stores the record. The important thing is that these records are, well, secured, in terms of appropriate, say, encryption mechanisms, for example. And once you have achieved that, then what you can do is you can even, well, decentralize custodianship. And this is where we're coming from with our personal data store concept, where health information is one sensitive, extremely valuable type of information that pertains to patients. If you have abstractions that allow you to maintain the privileges to this data in a precise way, and if you have solid encryption for all the data, then it doesn't matter where the data is physically held. The person who's got the key can be the patient, right? So
but you're not saying
the answer is you could have a data center that hosts all these data stores, and you've managed to successfully distribute the risk by giving the keys to, well, individuals, right? So that's, in some way, that's the ultimate security mechanism. But of course, we realize that not all countries operate that way. So here in New Zealand, if a DHB, District Health Board, wants to be the custodian, and if that's the way of doing things, well, that can be done, no problem.
Thanks.
Thank you, Sir Jorn and Sir Terry. Maybe now we can hear from Dr. Alvin, then Sir Vish.
Hi, Jorn. I'm Alvin. Thank you for accepting our invitation to talk. I actually, when I read your article, the one that you shared to us, it resonated very much with a set of principles we defined way back in 2014, that the end users should be part of the design process. So when I saw that blog of yours, I thought of inviting you to talk to our community. You mentioned something about having worked in the Philippines. Do you have projects in the Philippines, Jorn?
Well, our technology partner obviously is working in the Philippines, and they're also working in other countries in Asia and internationally. Okay. But our healthcare work at the moment, we don't have projects there in the Philippines. Okay. I personally have worked in the Philippines. That's, I think, over 20 years ago. So really, I still have fond memories.
Okay. So I think there's an opportunity in the Philippines. So if you can connect me to your group that are working here, not in healthcare. Terry knows this. I've known Terry for more than 15 years. We are the largest open MRS implementation in Asia. I don't know now. I mean, I thought we were before. We had 140 plus. And my question, so when we started OpenMRS, it was just, open source is the best.
Yes.
I mean, it's the most liberating technology. But we came to the point where the end users started to diverge. They started to understand what an EMR is all about. They started to imagine new ways of doing things with the EMR. And there were now 140 different ways of moving forward. And we came to the point where, how are we going to manage? This is a good problem that they have now seen the benefit of an electronic medical record. But I think we hit ourselves in the foot, because now there are 140 different requests of evolving the software towards different directions. Of course, I'm exaggerating when I say 140. Maybe 5 or 10 different directions. Some shared by 10 facilities, some shared by only one facility with another. How do you manage? It's a good thing that end users are starting to imagine new ways to evolve, but they're evolving in different directions. How will you manage that, Jorn?
Um, this really gets directly back to what I was explaining about the difference between the project mindset, the product mindset, and then the product line mindset, right? So if you try to productize things and standardize things, then you are in this product mindset, and it tends to work well, when you have 3 customers, you can usually, easily straddle them, and you come up with also, if you then make things configurable, things are still manageable, right? I mean, you invent a few switches, and you can cater for 3 ways of doing things, and things still seem quite nice. But if you reach 30 customers and 300 customers, right, or 3,000, then you're on a very different terrain. And this is exactly what domain analysis is about. So we are strategic about looking at this whole topic of configurability. So this isn't an afterthought for us, right? We, right from the first day, we say, well, we don't have one customer. So here, the CAD platform has been built with a model of the entire healthcare delivery ecosystem in New Zealand. So we've already, this is part of the reusable data assets, right? So I think we've got, I don't know how many 1,000 organizations in the country that ultimately are involved in healthcare delivery. They are all part of a formal data model. They are integrated into this. So all their core information is already part of our system. The only thing that we don't know is we don't know their detailed internal ways of working. And what we actually discover in our domain analysis in healthcare is that the processes used by organizations, they do indeed vary significantly. And so this is where there is a chance, of course, for some sensible regional level of standardization, so that organizations that need to collaborate on a regular basis so that they can actually do so effectively, and you want to actually put real attention to this cross-organizational work, that those interfaces work smoothly, both at a technical level and at a human level. But if you've got healthcare delivery organizations at different ends of the country where, patients that live in these different places, they never get to see certain operators. And it doesn't matter whether they use the same process or not. It's completely irrelevant. In fact, the population distribution and the needs of the local population may be very different. So it doesn't even make sense to have a common process there. And understanding those dimensions of variability and making them explicit in the configuration tools that you expose to people. This is the important thing, so that you don't overwhelm the people who need to do the configuration, because so that's the where we put the focus, so that we not only support the end users in their daily work, but we have, our aim is to provide the same level of support to the people who are doing the configuration, to make their life easy, so that they can deal with, with a much larger number of end users than they otherwise could.
So you are both an architect that models, and then you build your models into actual implementations.
Yes, and this is possible because, well, we use a low-code platform, and everything that all of our functionality is specified in formal models. So really, creating new functionality is absolutely not the bottleneck. I mean, we don't need to reinvent that wheel. So we operate at the speed at which we can understand the concrete needs on the ground. So once we understand the needs, we've got that type of functionality within days, right? So that's not the bottleneck.
So we have a lot of Australians in the call. So I'll call one of, so in AeHIN, we have a subgroup. We are the enterprise architects. we do the models. And our mentor there is Vish Viswanathan, who's in the call right now. Vish, are you there? You also have questions for Jorn, right? Go ahead, Vish.
Thank you, Dr. Alvin. I'm in Sydney, by the way, fellow Australian. Hello. The question is that I'm not starting my video because I've already passed our bedtime. You don't want to see me in my bed clothes. So the question was more like, I was trying to understand your presentation that I think there are two things. One is you've got a CAD platform, which the platform you've built, and you've got all the tools around it, to manage the whole thing. So who is your customer? Your customer, for example, Ministry of Health in New Zealand. You have to go to them, and then they have to accept your platform and your consultancy and integration, everything, and you work with them to develop the whole thing. Is that the model? That means you got the, as Dr. Alvin was asking, you got the internal platform and the tools as well as the consultancy expertise. But who is committing to that? Do you think the Ministry of Health will commit to the whole thing? Or how do you go about it?
Well, first of all, I mean, we are well familiar with both Australia and New Zealand, right? And in terms of the level of bureaucracy, I think in New Zealand, we are luckier in this case than the lucky country. Because we don't have these, well, you've got the federal government and then the states, and every state is doing their own thing. Over here, the Ministry of Health, they specify a whole number of standards, and we're directly working with those people. In fact, we're advising them on some of the current interoperability standards. So that's something that I think you'll hear more about in real detail next week, or when my colleague Keith talks about that topic. But the core people that we engage, the organizations here in New Zealand, that would be the district health boards, who are receiving funding from the Ministry of Health to deliver healthcare services. And it's the DHBs in our country that are then also in charge of distributing this funding to primary healthcare providers and to deliver services and to get services to the people. So we've got very good connections to a whole number of district health boards. We're also collaborating closely with the New Zealand Nurses Organization, who is involved in all district health boards across the country. So we've got an excellent network of local domain experts that support us, and then it's a matter of building trust with the CEOs of the district health boards, and then engaging them in practical work. And what we find is that these healthcare providers are heavily overworked. So that's why in parallel, we engage with local communities to independently find out what some of these really underserved communities need, so that we can already bring some community co-designed solution proposals to the DHBs, and bringing community representatives into these types of discussions with those at the district health boards that are then charged with designing and delivering solutions. This is something that's new to them, and they appreciate that we are doing a lot of the legwork that they simply don't have the headspace to do.
No, I understand. And I was trying to relate to Australian situation where there are so many state governments, and within New South Wales there are about 10 different area health offices, each one doing their own thing. And there are a lot of proprietary solutions being introduced into the hospitals and that kind of situation. So also looking at it from other countries' point of view and regional point of view, I was trying to see where is that you can, replicate what you've done in New Zealand and how you do. That's what I was thinking. So
Well, the CAD platform is this perhaps worthwhile pointing out. It's not New Zealand specific. I mean, the New Zealand specific part, that's at the data instance level. So that's the first, the most complete populated instances that we have relate to New Zealand. but it's designed from the start to actually also work in Australia. And my colleague Keith, he's based in Brisbane, so he's been active in health informatics in Australia, I think, for at least 15 years. So he is very acutely aware of the structures over there. But we're also aware of the higher levels of bureaucracy, and things are moving slower over there. We're not as well established in Australia yet. So if you want to help us change that, you're welcome.
Thank you. The last, before you go, I know the time is up. From a regional perspective, see, our group is reach is across the whole region. There are dozens of countries. So where do you think this platform, for regional cooperation, do you have any kind of top of the head suggestions as to how we can use it?
When you say regional, do I understand?
Asian region, like Philippines, Malaysia, Thailand, Indonesia. Where AeHIN is actually involved in all these countries.
Yes. So I think that's why I talked about the CAD platform rather than the patient journey management product line, because the reusable parts are really, at this level of reusable assets. And the structures that we've got there, I think they are highly reusable. They can be used in any of these geographies. So there is, I think, great potential for reusing this in other places. So I think we've identified the most salient dimensions of variability. And if you have good domain experts that know something that we don't yet know, well, we are keen to then build that into this platform. The other thing that's worthwhile noting is, again, to come back to this topic of interoperability based on open standards like FHIR. That's what Keith is going to talk about next week. So we make sure that our CAD platform is able to communicate with other systems using those standards in their most current form. And this is where we can offer assistance to organizations in other geographies to ensure that they expose information in this interoperable format. And this is, I think, the key going forward for regional cooperation and collaboration, because it's only if you attach the right significance to these interoperability standards that you don't get bogged down by a morass of point-to-point interfaces, which is sadly the reality that I think we still face in, certainly even within countries, right? I mean, we're at the very beginning
within
of
facilities
getting traction with this.
Yeah. So, Jorn, we've reached the top of the hour, but I'm happy that we're seeing each other again next week. I hope you'll be there with Keith. I'll be sending you an email if there's some demo or sandbox that we can start testing between now and then, so we can ask more useful questions, more practical questions next week. So looking forward to Keith and maybe Jorn again, and maybe Terry and Vic again next week.
I'll be there next week.
Okay, and then we can.
I'm just about to send you a question offline.
Okay, and right after Keith's talk, maybe set aside some time to talk about what to do with the platform and with the partnership. All right, guys. Thank you.
Brilliant. Thank you
care.
very much.
Thank you, guys. See you, Keith, next week. Bye.
Bye.
See you next week. Bye-bye. Bye.